Okay, it might be you, the only one that's left. It says we got 28 here, but some people have left the room. They've left the building. Okay, so let's move down a little further along this digestive tract. Oh, somebody else is. Somebody. I guess somebody's got a microphone on. There's feedback. Um, I think we're okay now. I'm not sure what happened there, but I was getting some feedback at my end. So what we're going to talk about right now are a group of diseases or conditions called the diverticular diseases. These are diseases that primarily affect the large intestine. So you can appreciate that what we're going to see as far as symptomatology goes is more related to the way things come out at the other end. So diarrhea or constipation are more likely to be the types of scenarios we're going to see here. So diverticular disease, or the groups of diseases related to diverticulitis and diverticulosis, are basically conditions where there's some herniations along the length of the colon. And if you weren't sure what the term herniation refers to, is it's a weakening of the wall. If you could have an aneurysm, which is a type of herniation in a blood vessel, and when we have herniations in the large intestine, it's a type of diverticular disease. It's going to be either known as diverticulosis, which is a very general term just describing these herniations. So basically, it's very much related, high risk from low fiber diets. And what happens with low fiber diets, it slows overall motility in the large intestine. So the pressure that's exerted by the feces, the mass that's been undigested but not yet eliminated, it increases pressure and causes weakness in the muscularis. That chronic stretch on the muscular wall is going to cause weakness and create pouching or out pockets, sometimes it's referred to as, but those become little potential cluster areas for bacteria to fester and colonize and become imbalanced from the regular flora that grows in that large intestine because of this increased concentration. So typically with diverticulosis, it's probably has about a 50% prevalence in those that are more than 60 years of age. So it's pretty common. And typically, it's asymptomatic. So it's not going to present with symptoms unless there's something that sort of tips the balance. So we'll talk about what that might be in a minute. But if there are symptoms, they're going to be pretty vague and not very helpful. So the person might complain of a bit of bloating or a little bit of cramping, maybe some gas, but that can happen for all kinds of reasons. So it's not very specific as far as that kind of thing goes. If it gets irritated, diverticulitis. So that's indicating that there's an inflammatory component to the presentation. So these herniations become inflamed. For those reasons I mentioned, the bacterial colonization overtakes the normal growth and balance that would. So now we've got an inflammation, probably going to give rise to some fever, maybe some more acute type of lower abdominal pain. And what's sort of classic for this presentation is that we get variations between constipation followed by diarrhea and vice versa. So the diarrhea is a result of the inflamed accumulations, creating swelling and therefore getting a little bit of motility, but loose, runny stools. And the constipation is what was causing the irritation and the problems in the first place. So this low fiber diet, slowing down overall motility, giving time for the infection to set itself, followed by that presentation. So a percentage of these patients can be treated effectively with antibiotics, and in some cases may require some surgery to get rid of those out pockets or those pouches that provided colonization locations. Now, staying with the large intestine, we're going to talk a little bit about a condition called Crohn's disease. And again, not a very helpful name because it's a person's name, but it's more accurately described as a regional enteritis. So when you see regional, it's really saying it's localized, but it may be over a relatively large area. But what we're going to see is what are described as skip lesions. So areas of irritation followed by areas that seem perfectly normal. But that's kind of the classic presentation for Crohn's disease compared to ulcerative colitis, which presents very similarly till you take a closer look. So when we look at Crohn's disease, it's described as regional with skip lesions. So we get inflammation of the GI, and here's the key. It's going to extend throughout all 4 layers of the intestinal wall. So inflammation and injury to all 4 layers of the intestinal wall. And it's most commonly occurring in the proximal part of the colon. So that would be mostly associated with the ascending component of the colon. So remember when we drew our picture way back in layer 1, this portion right here is the ascending colon, and maybe to some degree in the transverse colon. But when we talk about proximal colon, we're talking about the early part of the colon. When we get down to the rectum and the sigmoid colon and the anus, we're talking about the distal colon. So that's our location. The signs and symptoms are going to be very similar to ulcerative colitis, which we'll talk about in just a second, but possibly a little more consistent with the abdominal pain, not enough to be a difference maker. So we'll talk about signs and symptoms. In just a second. So basically, the mechanism behind Crohn's disease is primarily unknown, where we are not, there isn't a common etiology for this condition as of yet. We know that the lymphoid tissues become blocked and then engorged and scarred. We know that the ulceration goes through all the layers and creates what are called fissures, deep, deep injuries deep into the tissues of that uh, intestinal wall. And there's a lot of repair, obviously, disorganized repair, granulation tissue. So when we look at the presentation, at a cellular level, what we see is lymphoid tissues are blocked, engorged, which just means they're filling with fluid. That leads to inflammation. And the inflammation is going to lead to ulceration. Remember, we mentioned it's all layers. That gives us fissures, those deep, deep wounds with lots of granulation tissue collections. So those are referred to as granulomas, areas of tissue repair. And that's sort of the diagnostic feature on a biopsy, is these granulomas. So unknown etiology, which I believe we correctly we corrected ourselves. Idiopathic is the term we want to use when we're talking about an unknown etiology. There's probably a genetic component, almost definitely a genetic component, that is triggered by some environmental factors. They may be dietary related. For example, we know that in some parts of the world, the Crohn's disease is almost undiagnosed, unheard of. But when those people from other parts of the world with a completely different type of diet come to North America, all of a sudden their incidences of Crohn's disease go up and get close to what we expect to see in the North American population. So that points to some environmental / dietary factors that probably play a role. It's probably some sort of a trigger on an otherwise quiet genetic pathway that needs to be exposed to some sort of food or something common in the North American lifestyle. So treatment is mostly symptomatic. We don't have a cause, so we can't get rid of that source. So we're going to treat the inflammation. So corticosteroids, as long as they're short term, is the treatment of choice. There's no cure, so these are symptoms that someone's going to have to live with, literally. And if we compare that to ulcerative colitis, the symptoms are similar, the treatment is similar, but the actual pathogenesis is different. So this is chronic. You know, the Crohn's was often episodic, but it could be chronic as well. It's chronic inflammation. And some ulceration, obviously, from the title. But mostly of the mucosal layer. So that's different and a little more distal. So the location and the depth of irritation is different. So the manifestations are similar. We're going to get abdominal pain, cramping, what happens, there's some weight loss because of the chronic nature. So in this case, we've got fresh blood in the stool because the irritations are closer to the point of exit. So rather than the tarry stool that we saw in gastric ulcerations, we're going to see a bright red indicator that the bleeding is closer to the end of the intestine, end of the digestive tract as far as that goes. And the way that this looks like under a microscope is that we get our inflammation, we get some abscesses, pockets, but they coalesce rather than skipping, they join together. So they create a larger area with scarring and the granulation tissue, but the granulation tissue is much more widespread. Remember, we call the granulation tissue in Crohn's disease a granuloma, so it's a cluster, an area that's a cluster of this granulation tissue. In this case, we've got this granulation tissue spreading, and of course that decreases the colon ability to absorb water and electrolytes, which is typically the final step in the digestive process going on in the large intestine. So these patients are at a higher risk for colon cancer if the signs and symptoms persist over a period of years. So typically the risk factor significantly increases if symptomatology is chronic and lasting approaching, say, 10 years. Again, it's a risk factor. It's not a cause, but it is a risk factor. So again, people that are at risk for this are for both conditions, but particularly with ulcerative colitis, there's an increased risk with our so-called Western diet. Increased risk with alcohol, with smoking. And an increased risk, which is probably really part and parcel with the Western diet, but with more refined sugars and fructose, which is really a type of refined sugar. Now these risks, again, these are risk factors, they're not etiologies. So there's a little bit of controversy in the literature as to how much of a role these things might play, but we do know that there's a definite pattern of risk associated with these types of lifestyle choices and the presentation of ulcerative colitis. Okay, so treatment again is like we talked about with With Crohn's disease, it's going to be anti-inflammatories, particularly corticosteroids for the short term and based on symptoms. So in other words, you're not going to, this is a more chronic problem, so it's going to, chronic use of corticosteroids leads to its own set of problems, which we looked at and saw, and you might not have yet, but you will when you see the stress response, what happens with chronic levels of cortisol to the various systems in the body. So that explains why long-term corticosteroid treatment is not a recommendation now that we know what that will do. Any questions about ulcerative colitis or Crohn's? Okay, so now we're looking at the pancreatical biliary system. If you weren't sure what that mouthful refers to, is we're going to be talking about the pancreas and the gallbladder here. We leave the liver for 401, so we'll just be talking about some things that can go wrong between the pancreas and the gallbladder. So just a quick review. Remember, our liver is this two-lobe structure like that, and sitting tucked underneath the liver, sort of covered by the liver, is the gallbladder. And the gallbladder receives bile from the right and left hepatic ducts and empty into the common hepatic duct to travel to the small intestine. And before it enters the small intestine, it typically joins up with the pancreatic duct that is draining the collection of alkaline fluid and enzymes, also to empty into the small intestine. I don't have that quite anatomically accurate. The stomach needs to be in between here and the small intestine, but as far as the small intestine goes, that's the relationship that we're going to see there. So the duct from the pancreas drains into the duodenum, the duct from the gallbladder drains into the duodenum, and bile is produced by the liver. So the bile is produced and collected. Hepatocytes produce the bile. It's collected up by these right and left hepatic ducts to join in at the common hepatic duct. And from the common hepatic duct, we're going to drain down into the small intestine. If we're in between meals, then the sphincter that drains into the small intestine closes a little bit and the bile backs up into the gallbladder. So the gallbladder stores bile. It doesn't produce any bile, but it does store bile. And enzymes and an alkaline juice are produced by cells of the pancreas. These would be described as exocrine because they drain their product through a duct into the small intestine. The alkaline juice is going to neutralize the acids from the stomach, and the enzymes are categorized as peptidases that work on proteins, lipases that work on lipids, and amylases that work on carbohydrates. So once we get into the small intestine, we want to complete as much absorption as possible in especially the jejunum, the middle part of that small intestine. So we've got to really have a lot of enzyme activity. And remember that the mucosa was made up of villi, and on top of the villi were microvilli, So we created that brush border that gave us a huge surface area in the small intestine for lots of more exposure to enzymes and time in the small intestine to finish the job of digestion with those enzymes and then absorb. And remember, when we absorbed into the circulation around these intestines, and the first place we went back to was the liver. Liver got first pass metabolism, first options on the carbs, lipids, and proteins that we digest and absorb, so that the liver then makes a determination on what goes into the circulation for utilization by other cells, but the liver gets first option on everything. So remember the purpose for bile. Anybody tell me what the purpose of bile is?
I could. To carry waste.
Okay, that's one purpose, certainly, but there's a digestive purpose.
Doesn't it change the acidity of the chyme coming out?
Well, not significantly. There's not enough volume for it to have a big effect. That's mostly going to be the job of the pancreatic juices. So the bile has two primary responsibilities. One of those is to transportation of waste, especially the breakdown of the old red blood cells, bilirubin. But the primary role from a digestive point of view is that it emulsifies fats. Remember that term, emulsification is a mechanical type of digestion. So it literally will emulsify or agitate fat globules into smaller globules, making them more likely to be able to be absorbed. So it aids in the mechanical breakdown of lipids. And it carries bilirubin to be eliminated through the feces primarily, a lesser amount through urine, but primarily through the feces, and eliminates some of our immunoglobulins and other toxins from the body in this way as well. So remember, the pancreas is exocrine, and that's what we're talking about when we look at this picture. We're talking about the digestive enzymes and the alkaline juices that neutralize the acids from the stomach. But we also know that it has a major role as an endocrine gland, produces insulin and glucagon, and a couple of other ones. We're not going to be too worried about those. We know that insulin lowers blood glucose, and glucagon is antagonistic. It's going to raise blood glucose levels. So we know that the gallbladder stores bile. So what can happen to the gallbladder? We can have something that's called cholelithiasis. Fancy mouthful. Cholelithiasis. If you see chole in the root of a word, it's probably got something to do with the gallbladder. The gallbladder a component of bile is made up of cholesterol, and that's where the chole part comes from. So it's also one of the ways that we eliminate some of the cholesterol from the body. So that's another component to bile. But cholelithiasis refers to a gallstone. This is a gallbladder stone. So it affects about several million people in Canada alone every year. So it has a pretty high prevalence amongst our population, adult population. It's the risk profile for somebody who's more likely to get gallstones is somebody that's got sort of middle-aged. There used to be a very unflattering mnemonic to remember this: middle-aged female who's overweight, so the mnemonic or the memorization thing they used to say, which is very very generic and very offensive in so many ways, but it is easy to remember, and that is that they were fat, female, and 40. That got you your middle-aged, your risk factor being more likely to be female and overweight at the same time. So that was your 3 F's that became your risk factors. So the risk factors were that you're middle-aged. We're not going to, I guess that is recorded, but I'm not going to write it down. It used to be acceptable. I don't know if it's in your textbooks anymore. I used to see that actually written down as far as that goes. So these gallstones may be asymptomatic, and if they're asymptomatic, they don't need to be treated. Because basically what happens is in situations, these gallstones block the release of chyme from the gallbladder. And so the gallbladder, if it's being called because of content in the duodenum to release I think I said chyme, I mean bile, into the small intestine, and it can't do it, it continues to contract. So that's where your symptoms of a gallbladder attack come from. You tend to feel sort of cyclic contraction, relaxation, cramping, or acute pains associated with the contractions of the gallbladder trying to get rid of the bile, because the signals from the small intestine are saying we need some bile because we've got some lipids and some proteins in here, and we want to counter those. We want to continue the digestive process. So the other, I knew there was a 4th F. So basically what we know is an increase is somebody that's on birth control medication. So they used to say you were fat, female, middle-aged, 40, and fertile, because you were still on the birth control pill. So those were all risk factors that came into play here with the letter F as the mnemonic. So basically, other than those risk factors, if there's a history of diabetes, if there's a family history, if there's liver disease, those sorts of things will all favor the increased possibility of gallstones. If someone doesn't take in a lot of fluids, this is very similar to kidney stones as well, then the risk goes up. Someone who's got a bit of a vitamin C deficiency, the risk goes up. These are factors that would increase the possibility of gallstone formation. So these stones typically have a cholesterol component, and they can vary in shape. So obviously the bigger they are, the more symptomatic they're going to be. When they're mostly cholesterol based, they're often asymptomatic because eventually they can be broken down through the muscular contractions. But if they have, in addition to the cholesterol, they may have some what are called pigment based. These are bilirubin. And bilirubin is responsible for the brown in the stool color. So that's where this pigment reference comes to. And probably some calcium associated with these. These are the next most common type of stone that can form. So cholesterol alone is probably the most common type of stone that forms. And then the next most common is the cholesterol with some bilirubin and calcium. And then you can have a mixture of all of them with some additional bile salts as making up the formation of these stones. So again, often they remain asymptomatic. But if you did an ultrasound and looked at the gallbladder, then typically what you're going to notice is that the gallbladder is filled with stones. I don't know if your textbook shows it, but it's an easy thing to look up. You can see that sometimes these gallbladder attacks, when they do an ultrasound and actually look at the gallbladder, it's jam-packed with cholesterol-based stones. And it's amazing that any bile at all is ever going to get released, because the bile may be in between these stones, but if a stone is sitting at the exit point or anywhere along that cystic duct, then the bile has nowhere to go. And then that's when the symptoms are going to present, and the symptoms are going to present just the way it happens sometimes in the digestive system, is that you got smooth muscle contractions that aren't going anywhere. So it becomes a bit of a positive feedback loop where you're going to get contractions that aren't resulting in relief. So you get stronger contractions, and that's what a gallbladder attack is referred to as, or is caused by, this chronic or recurring contraction relaxation cycles. Now, some people get what's called chronic cholelithiasis. And in chronic, you get intermittent obstructions that go into remission on their own. So, but when there's an obstruction, there's often a lot of pain. There's nausea. There can be vomiting, sweating. I myself have been through this, and it's a very uncomfortable scenario. And it's a little bit of a mystery till you get the diagnosis. So the best diagnostic is ultrasound, like we mentioned, that is going to give you a view of that gallbladder, and then you'll be able to see the stones in that location. So that's recurrent blocks So lots of people will go through chronic lithiasis and maybe not get diagnosed because it just feels a bit like cramping, although it can get very acute. But some people may not go looking for any answers because it's temporary, a day or two, and then you feel better again, and you might go months before you have another episode. So that's chronic, which is better described probably as recurrent. Then you can have an acute. Oh, so, actually, this is a different story. Where's my, oh, now we got this thing in the way. So this one that we're about to talk about is not a stones issue, it's an inflammatory issue. This is a cholecystitis. So chole, so you know it has something to do with the gallbladder, and then it's an inflammation. And when you've got a cystitis, it's inflammation of a sac. So this is, we're talking about the gallbladder itself now. This is gallbladder inflammation, and if it's recurrent, it becomes fibrotic and may develop into a blockage or a thickening that leads to a blockage. About 90% of these have stones that end up obstructing the cystic duct so that the bile can't get to the small intestine. And the risk with blockage is that you could get perforation because the stones with calcium especially are going to be sharp, and they can cause perforation leading to a bacterial infection. So these are things we're concerned about with respect to the gallbladder. And when the gallbladder reacts in this way, it's a very severe, often right-sided upper quadrant type of pain. So you know that when we look at if this is our diaphragm and this is our pelvis, we can divide the abdominal cavity into quadrants. So in this case, if we're talking about the anatomical position, here's our right upper quadrant. So that's the common location for acute cholecystitis that might be caused from a blockage, but at any rate is going to cause some severe symptomatology. Again, a diagnosis by ultrasound is your sort of classic best way to diagnose that it's coming from the gallbladder. Okay, now when we look at the pancreas, I'm just trying to hit high spots now to get it covered, because I want to be able to get into the cardiovascular system next week. So when we look at the pancreas, we've got acute and chronic pancreatitis. So you can tell again with that suffix itis, we know that it's an inflammatory condition. In acute, we're talking about usually a little more intense, quick onset and very acute symptomatology. So when you're talking about an acute pancreatitis, the concern is that there's going to be a backing up of the enzymes, and the enzymes are going to start to auto-digest. They're going to start to digest the tissues of the pancreas itself because they're not able to be released into the small intestine. So if there's an obstruction of the pancreatic duct, if there's some sort of problem with intracellular transport, which is not uncommon with alcohol abuse, for example, then we have the possibility of an acute pancreatitis episode. This would be left-sided upper quadrant pain, tender to palpate. So in other words, you can palpate under the rib cage. It's going to be tender. Nausea and vomiting are associated with it. Lab tests would show elevated levels of enzymes, increased amylase, which is really a group of enzymes, and increased lipases. So that's laboratory work. Those levels would be elevated in the blood. And in this case, a CAT scan of the pancreas is sort of the gold standard for treatment. It's going to show the pancreas in detail, and we'd expect in this case to see abscesses and cysts and swelling of the tissues, the exocrine portions of the tissues in the pancreas. And we have to differentiate from an ulcer or a gallbladder problem, but otherwise the CAT scan is going to do our differential for us here. So the biggest issue we've got is that the problem in this situation is catabolism. We're going to have a problem with the enzymes starting to digest the pancreas rather than digesting food. And we're going to end up being a patient is not going to want to eat because they're not digesting or absorbing effectively. So there's a nutrition imbalance that's established in this scenario as well. So these patients may need some kind of extrinsic support for a recovery to occur because of the catabolism and the decreased caloric intake. They need nutritional support. And the concern, if it's not corrected, is that the tissues are dying and there's an increased chance for bacterial infections. It can lead to problems in the respiratory system, and the kidneys can be affected. So it becomes a life-threatening, acute pancreatitis can be a life-threatening problem as far as that goes. In the chronic scenario, you're dealing with a patient's history that indicates that they're abusing the pathways to the small intestine. So people that have chronic abuse of alcohol, have chronic hypercalcemia, or simply idiopathic, unknown reasons for why there's a chronic irritation to the pancreas. But the same concept applies, it's just a more gradual onset. We're going to get necrosis of the pancreatic tissue because of the enzyme actions on that tissue, leading to scarring and calcification and obstruction. The difference is that an acute episode will onset minutes to hours and needs to be addressed in that time frame, whereas in the chronic situation, it's weeks to months for onset to develop. Okay, so what I would suggest you do, because of the shortness of time and the vagueness that I just went through, is spend a little extra time self-study on the gallbladder and the pancreas. Okay, we did pretty good on details of the rest of the digestive tract in terms of what you're responsible for. So spend a little extra time with your PowerPoints and the textbook on the gallbladder and the pancreas. We covered the topics, so acute and chronic pancreatitis and the different cholecystitis versus cholelithiasis for the gallbladder. So anything you see describing, for example, pancreatic cancer, no. Okay, we got the topics listed in this recording. So that's what you focus on, just to support for a little bit of self-study there. Does that make sense? We okay with that?
Yeah, sounds good.
Okay, so let's call it a day. Next week is week 6. There's going to be a quiz. I'll put an announcement out when I get the quiz made and get it ready. You may have seen the announcement I placed today that says from now on, the quizzes and the tests are going to be using a browser that's called Respondus Lockdown Browser. So you need to follow the directions in that announcement to download that browser for tests and quizzes that we have in our class. Okay, if you have questions about that, well, you'll get a chance to use it. If you haven't used it in the past, I know some of you have. It took me a long time to figure out how to get this thing to work. But at any rate, we'll have it working now, I think. And so we'll try it with the quiz first and see how it goes.